Hello, everyone, and thank you for joining us for the 2021 Virtual Hill Day. I'm Debbie Plotnick. I'm Vice President for State and Federal Advocacy here at Mental Health America in our national office. We're so happy you could join us today. And we've got a tremendous program coming up, a very full agenda. We're going to be looking at what happened over the past year, the trends in MHA screening data. We have special remarks from Representative Chu. Representative Smith did send some remarks, but they were a little hard to hear, so we'll have to fix that later. Peer support and equity is going to be discussed by two of the most outstanding people in the field. We're going to hear a federal update. We're going to learn about what we should be asking about and how to take action. We're going to leave you with a charge, and then we'll be happy to do questions and answers. I want to remind everyone that participants are in listen-only mode, but the webinar is being recorded and you can listen to it again at a later date. And we hope you're going to have questions for us. Please enter them in the chat. Just use your chat function here and it'll be answered during our Q&A session before the conclusion of today's webinar. With that, we're going to get right to it. Karen Howard, who is our Director of Advocacy and Policy, is going to be giving us a rundown of the screening that we've seen in 2020. It's an eye-opener. Karen?
Hi, everyone. Thank you, Debbie. I really appreciate the opportunity to be here with you all today. And we really appreciate you tuning in. So MHA Screening Program is an online tool accessible at mhascreening.org. It began in 2014, and in the last couple of years, people were able to add demographic data by choice, and most screeners we found are voluntarily giving that information. Screeners are young, 73% of them are under 25 years old, and screeners are more often than not female. 73% of screeners are women. And it's a help-seeking population, which means that people are screening positively more often than the general population does. Otherwise, the screeners are very representative of the population. I want to go over just a few trends that we found in 2020, thanks to Madeline Reinert, our Manager of Population Health, who is the person that we go to for all things screening when it comes to statistics and data. So as you all probably know, over 2.5 million people took a mental health screen in 2020. And this actually was the largest data set compiled for a mental health help-seeking population during the pandemic. It represents a 200% increase over the number of people who completed a screening in 2019. Based on monthly averages so far, MHA projects that this year we'll see over 3 million screens. Even with that increase in the raw number of people taking screens, we saw the percentage of people screening at risk as well. This means the increases weren't just from increased media or growth of the screening program, but it represents an increase in mental distress throughout the country. Since June, the proportion of people who took a screen and scored with moderate to severe symptoms remained above pre-COVID-19 levels, and that has remained elevated through 2021. The largest increases in the people scoring positively from 2019 through 2020 were for parents and youth, followed by increases in PTSD, anxiety, and substance use. On average, 91% of the 11 to 17-year-olds who took a depression screen in 2020 scored positively for moderate to severe depression, and 84% who took an anxiety screen scored positively for moderate to severe anxiety. 11 to 17-year-olds were the largest population or age group to screen positively for depression and anxiety, and they were screening more severely. In March and April of this year, 2021, 42% of individuals who took a depression screen reported experiencing thoughts of suicide or self-harm, more than half or nearly every day, which was 11% higher than the average rate of suicidal ideation in 2019 and totaled over 110,000 people with frequent suicidal ideation in the 2 months in March and April 2021. So in addition to overall seeing an increase in depression, anxiety, we're also seeing increased suicidal ideation and severe ideation, where people are reporting more than half or nearly every day having thoughts of suicide. Oops, sorry. A couple of other stats before we go into the next slide. We had over 51% of youth depression screeners reporting frequent suicidal ideation, which is 2% higher. And then even higher in 2021, we had over 52% of 11-year-olds reporting suicidal ideation, more than half or nearly every day in 2021. So we're seeing the numbers continue to increase, though COVID-19, as you all know, the pandemic restrictions are starting to loosen, people are getting vaccinated, and there has been some overall return to normal or plans to return to normal operations across the nation, depending on your state. Rates of frequent suicidal ideation are higher among people who identify as LGBTQ, particularly among LGBTQ youth, and that acronym stands for lesbian, gay, bisexual, transgender, queer, or questioning. 64% of youth ages 11 to 17 who identified as LGBTQ reported frequent suicidal ideation from January through April 2021, 4% higher than the average reported by LGBTQ youth in 2019. And then finally, rates of suicidal ideation continue to increase and be much higher in 2020 and 2021 than in 2019 for screeners of every race and ethnicity. The proportion of people reporting frequent thoughts of suicide or self-harm was highest among Native American or American Indian screeners in 2020. And the largest increases in the proportion of people experiencing suicidal ideation was for Native American and Black and African American screeners. One group of paraprofessionals in particular that have been helping and being a part of ensuring communities are able to meet the needs of individuals are peer support specialists. As you know, Mental Health America has an advanced certification for peer support specialists, and 49 states currently have their own certifications. We'd like to share a message with you from Representative Judy Chu of California, who is our lead sponsor of the Peers in Medicare Act. As Debbie mentioned, we did receive remarks from Representative Adrian Smith from Nebraska, but we think you'll have trouble hearing them, so we'll put them in the slides that will be available for listening later.
Hello, I'm Congressmember Judy Chu from California's 27th District, and as one of only 2 psychologists in Congress, I want to thank you all for participating in Mental Health America's Hill Day. And because May is Mental Health Month, it's especially great timing for all of you to be joining together today to talk about the importance of mental health. This past year has been so difficult for all Americans, but especially for those suffering from mental health and substance abuse disorders. During the pandemic, as many as 40% of adults surveyed have reported symptoms of anxiety or depression, which is up from just 10% of adults in 2019. Business closures, job loss, and prolonged periods of isolation have had a devastating impact on the mental health of Americans in every state. And so our job in Congress must be to ensure that our response addresses the huge need for mental health services in this country. That's why I'm so proud to have recently reintroduced the bipartisan Peers in Medicare Act with Representative Adrian Smith of Nebraska. My bill would clarify that there's nothing in current law that prevents peer support specialists from being included in coordinated care teams under the Medicare program, which serves our senior population. A peer support specialist is a person with lived experience who's been trained to support those who struggle with mental health, psychological trauma, or substance use. Their personal experience of these challenges provide peer support specialists with expertise that professional training cannot replicate. Peers do not replace clinicians the way psychologists or psychiatrists do, but they can bolster the mental health workforce at a time when it's already stretched thin. As we face shortages in the mental health workforce, peers can help supplement the services of clinicians, freeing up their time to see additional patients. For example, if someone comes out of long-term treatment for a substance abuse disorder, they could find themselves alone in an empty apartment just hours after completing treatment. At these moments when people are susceptible to feeling isolated, scared, and probably a little uncertain about the future, being able to reach out to a peer support specialist in that moment to talk about how they are feeling can be the difference that helps them make it through those first few hours of recovery. The patient could then follow up with their clinician a few days later for long-term coping strategies, but the peer would have been able to help with the immediate moment of crisis. This issue is important to me because as a psychologist, I have noticed that many in government talk about treatment and prevention, but there is a third step to the process, and that is recovery. That is why I'm so honored to have introduced the Peers Act, because it focuses on how we can ensure successful and long-lasting recovery for those among us who are struggling. And as a member of the powerful House Ways and Means Committee, which oversees the Medicare program, I'm committed to finding ways to continue to promote access to quality, affordable, and culturally appropriate mental health care for everyone. But I cannot do this alone. That is why it's so important that you are all participating today to talk to your members of Congress about the importance of this bill and other mental health priorities in Congress. I know that as a member of Congress, I pay very close attention to what I hear from my constituents, which is what makes days like today, even virtual ones, so critical. Together, we can build support for the Peers in Medicare Act and pass it into law. Thank you.
And thank you, Representative Chu, for those inspiring words. And thank you to Representative Chu and Representative Adam Smith for their bipartisan introduction of HR 2767, Peers in Medicare Act. Speaking of peers, we are going to hear from two of the most distinguished peer leaders in our country. We're going to hear from MHA's longtime friend, Charis Myrick, and Charis has a wonderful history of leading peer things at SAMHSA and through programs in LA and nationally, and currently she sits on the NAPS board, and she has some other important positions that she's going to tell you a little bit about, and she's going to be joined by Kelly Davis, by MHA's own Kelly Davis. And Kelly is the Associate Vice President for Youth and Peer Advocacy. And they're going to have a really important and timely discussion about peer support and equity.
I'm Charis Myrick, and I'm the co-director of the Mental Health Strategic Impact Initiative. I'm also on the board of the National Association for Peer Supporters.
Hi, everyone. I'm so grateful to be here with y'all today. My name is Kelly Davis. I'm the Associate Vice President of Peer and Youth Advocacy at Mental Health America. And my work focuses really on lived experience as something that should be the center of all that we do and how we transform mental health programs, policies, and organizations. Part of that work includes the importance of peer support programs and peer leadership. I'm really grateful to be here with y'all to talk about how we can expand access to peer support specialists and peer leaders. So Charis, I wanted to start off by asking you, you've been a massive influence and leader in the field of peer support as it's grown. I would love to hear your perspective on, where peer support is now over the past years and how the settings where peers are providing services have grown and changed as peer support has become more acknowledged as being an effective and essential resource.
Yeah, I mean, the things that have happened over the, I'll say decades, it really has just expanded and, blown up, I think, what peers have been doing. So, first starting off as, volunteers and doing what we call mutual support, and mutual support still continues, where these are folks who do things like AA groups or other type of maybe 12-step or working with people using that lived expertise to support one another. There may not be formal training involved, and they might be meeting in places like churches or, at the community centers and doing that kind of work. And then it's moved forward to looking at how to increase the consistency and reimbursement for the services that peers are providing. And so it moved from the mutual support to people who wanted to really work within systems of care, whether it be community mental health centers, peer-run programs, hospital, forensic settings. So trainings has come into place, some consistency with building core competencies and practice guidelines. So peers now can be certified. They're 48 states. California is kind of 49. We won't get into all of that, but let's just say 49 states that have peer certification, and that's just fantastic. And I remember looking at the map years ago where it was these different colors, and it was like 3 blue states. Everybody else was like not even anything happening, and now here we are at 49 states with peer certification. What are some of the things that you've seen as far as where peers are going, especially youth?
Yeah, I think that, I've been with MHA for 6 years. I think the interest in peer support has really exploded because I think people understand that the way that we orient and design mental health services does not best meet the needs of people. And at the same time, peer support has demonstrated its value as a direct service, but also as an agent to transform systems and organizations. So I'm seeing a huge interest in peer support programs, I think particularly as we're seeing and will continue to see the fallout and distress after a year or so in isolation from the pandemic and all of the social justice and racial reckoning that's happened over the past year and will continue as well. I think that what I've seen in terms of the expansion of peer support is, as you were saying, we always want to make sure that, and it will always continue to happen, that people just provide support to one another. It's very natural. You check in with people who've been there, right? But I think we're seeing a peer support in all types of settings. So inpatient psychiatric units, like you said, community mental health centers, peer-run organizations. I think there's a really important movement towards having peer specialists in emergency departments. We all know that people are boarded for hours, sometimes days, even though they're told to show up and go to the hospital when they're in distress. And we haven't designed the hospital, and certainly not the emergency department, to meet people where they are. Two, peer-run organizations that include alternatives to traditional mental health services. So having peer-run respite as a place where people can go instead of the emergency department, having peers on mobile crisis outreach. So we're not calling the police, but we're really meeting people as they are and with the resources that they need, so that they're not unnecessarily having interactions with the police, unnecessarily in hospitals, because not only are those not effective, they're really expensive. So it doesn't make sense for anybody, that we would design a system like that. So I think that there's really exciting conversations about how we transform, how we respond to people in crisis, but how we respond to people and support people in their workplaces, in high schools, in colleges, because the research is really demonstrating that peer support helps with people's mental health, but also their entire health and all of their outcomes and their sense of connectedness to the community and ability to navigate community-based resources, not just clinical services, not just access to social services, but like a whole comprehensive approach to what really makes life worth living, and letting people decide what that means for them. And I mentioned a little bit the kind of racial equity and justice conversations that we've had over the past year. I think in my experience, one of the really big barriers in the field of mental health is the underrepresentation of folks of color and LGBTQ folks and young people in the availability of peer specialists, right? And as a field that's about shared experience, it's a really massive challenge, but also a really big opportunity to invest in increasing the diversity of the peer support workforce. So do you mind sharing a little bit about some of the conversations that you've had and seen around diversity and equity in peer support and the peer specialist workforce?
Yeah, I mean, I'm going to back up a little bit and talk. I want to make sure that we talk a little bit too about the research and evidence. And I think that's one area that for sure we have seen even the role of lived experience helping to drive some of the research and evidence around peer support, and seeing that people who are experiencing homelessness are better able not to just get housing but to remain housed and to remain in community, connected to community, and having those community supports. Hospitalization and ER use is reduced as people, because they're remaining in community and connected to community, people do have the ability to better participate in treatment because they're understanding better how to do shared decision making and be active and engaged and participate in that treatment. And then, I always like to talk about too what parents and families, when they get support from each other, are able to do, which is also have a better understanding of how to support their loved one. And then for both people with lived experience and the family members, reduced stigma and shame. So I think these things are critically important because it helps us to, just helps our overall well-being. It also helps us to, participate in the things that help us to get better. As far as people of color, this is really interesting in equity. When I was first going through my struggles, I didn't see people who look like me providing services or in leadership. And I questioned somebody who had written an article about it. Turned out it was, a Jewish white guy who had written this article about this issue. And he mentioned somebody, Jackie McKinney, who's very well known to MHA. She was on the MHA board years ago. And I got introduced to Jackie McKinney, and that's the first time I saw someone who looked like me in a leadership position that gave me the hope and the belief that recovery is possible. And not only that, look how I can give back. This is so cool. So as we kind of move forward in time, I think, for folks of color, one of the things that we're experiencing, particularly now because of, racial injustice and racial reckoning, is like, where are we and how are we moving systems? Not just how are we looking at, cultural relevancy in the individual nature of how we provide support, but the conversation now has become cultural competency and cultural relevancy is only one part, that we also have to look at systems and system changes that really will impact the disparities that we are experiencing as people of color. So some of the things that I've been working on and I've heard about is making sure that work that we're doing in mental health and in the peer world is centered on that experience of folks of color, assuring that we address all systems and policies that perpetuate racism and disparities. So this is really now about systems level work as well as the cultural humility work. And that we want folks who are white to stand in allyship, but not just in the moment. It's consistent allyship around addressing and combating these issues of racism. The other thing that we've been talking about as well, or hearing about, is disparities that happen in crisis response. And that we know that, in fact, that for all people with mental health conditions, when there is law enforcement involved, we have really detrimental outcomes. But those outcomes are 10 times worse, meaning 10 times the death of people who are Black and have a mental health condition. So we work on things like 988 and crisis response system reform. It's really, really critical to understand the disparities that are impacting folks of color and the value and the role that peers can play in crisis response system reform. What are some other things that you think, Kelly, about what people should know about peer support?
Yeah, I think that it's a really important tie-in when we're talking about alternatives to the police and crisis response, is that peer support shouldn't be thought of as just something to be added to things that already exist, because the peer support movement has really existed as leaders in creating new types of services and creating new approaches to services from lived experience. I often say what can take 7 years of school can take a month of mental health services. So, you know, it's just the problems and challenges become really obvious when you're going through it. And those voices are really important. I think when we're talking about the expansion of peer support services, two major issues that we have to talk about is, one, when we're integrating peer specialists into different settings, we need to make sure that the staff and leadership know what peer support is, or trained in peer support supervision, because I think it's really easy to add a transformative service, not make space for somebody to be transformative, and put them in a role that is not designed for them and say it didn't work. So we know from years that training leadership, training providers, training the whole mental health workforce and policymakers in what peer support is and the power of peer support and the research is really important. I would say too, the other massive thing is when we're making these big investments in peer support, peer specialists should be reimbursed for the value of the service they provide. In many places, reimbursement rates for peer support services are very low, and peers are not. If we want to value the dignity of people, but also the value that they're bringing to the table and the ways in which they're improving outcomes, they're, you know, changing how and where we invest money in mental health services and in people, we need to really value them and not just say, oh, this is a cheap alternative to another type of provider. This is a really valuable transformative tool to help people live the lives that they want. So I think reimbursement rates and work and payment is really, really important to consider when investing in and talking about how we do peer support. Peers deserve living wages, and they deserve to be valued by systems and within the organizations that they're working for. And that is you know, legislative, regulatory, advocacy issue that we should be aware of as we work to expand access to the workforce. Would love to hear any of the other topics that, you know, you would want legislators to know about expanding and investing in peer support.
Yeah, for sure. I think, you know, legislators should also be aware of other types of programs that aren't fully funded, that could be funded or should be funded as part of the crisis response continuum of care. You talked a little bit earlier about peer respite. You know, how are those things funded? You know, we really need to look at ensuring that there's funding for a variety of ways in which peers might enter in to provide services in order to meet people where they are. We call it kind of like having the right place and the right person every time that a person needs some support. The other thing is we still know that there are mortality gaps for people, particularly with serious mental illness, people of color, that are greater, disproportionate to the rest of the population. So, you know, we really need to think about where peers are placed, especially in integrated care, and that there's reimbursement for peers in integrated care through Medicare, for other types of where primary care is involved, where people might go first to primary care. People might feel more comfortable going to primary care. You know, there's certain cultures where that's where they're going to go. The stigma and shame is still so high to go to mental health care that they're going to continue to see their primary care provider. And they should have access to peer supporters to help them with that mental health care. And it may be a way in which they're more at ease talking about that mental health care with somebody who looks like them, with somebody who's been through the same thing as them. So I think those are critical. And then the other critical point is that when thinking about, you know, legislation and the, you know, driving legislation, drafting legislation, getting TA from the legislative staffers, talk to people with lived experience and peer providers to help with that drafting so that the language matches our scope of practice and the work that we do, so that people will get the value of the services that are provided and funded and have the regulatory arms around it that make sense for the work that we're doing as peer supporters. Any last words?
I think just to note to your point that we don't want people to be failed for decades before they get access to a service that we know works. So I think what's really important is to prioritize investment in the peer support workforce. That means making sure that we have consistent funding streams, but to your point, for the different types of services that people with lived experience and peer providers provide, but making sure that we're providing living wages and wages that are that reflect the value that peer specialists bring to the workforce. So I think if we're at a point where we're going to continue to see a massive influx in distress and people accessing resources, we are at a critical time, a pivotal time to invest in a resource that has already been shown to really transform how we talk about and address mental health.
Yeah, and I'm going to add one more thing too around the funding, because this is where I think rubber meets the road, is that funding has to be flexible enough for peers to be where they can provide that service and meet people where they are. So people will not always go to community mental health centers, FQHCs, or CCBHCs. We have to go where people are, and the funding needs to follow us so that we can meet people if they're homeless, out where they're kind of living, and you know, at the bridge, wherever they are, that's where we need to be, and the funding and the policies need to follow us there. So I think that's another thing that is super important for legislators to know.
So much, Charis. This has been an awesome conversation, and thank you to everybody tuning in, watching this, for your dedication to ensuring that folks are supported in their whole health and well-being, including their mental health, and working with us and with all of our coalitions and folks who care about mental health to make sure that peer support is a key part of our mental health advocacy.
Thank you so much, our dear colleague, Kelly Davis, and our very, very good friend, Charis Myrick. We're going to hear a federal update now from MHA's Executive Vice President for Policy, Mary Giliberti, and you're going to hear through that federal update how some of the things come in that we just heard about. So, Mary?
Hello, MHA advocates. I am so excited to be talking to you today about the federal advocacy landscape. You know, when you go to a play, and many of us haven't been to a play in a long time, you get those program notes, and it tells you kind of the scene, what's taken place before, who the main characters are. That's what I'm going to do today. And then my colleagues are going to come in Act 1 and tell you all the legislative asks, the specific things that we want to move forward. And then this is an audience participation play, because then you are going to take action with your legislators to help us move this advocacy forward. First slide. So let's see the current composition of Congress. Let's set the scene. In the House of Representatives, we have a Democratic majority, 219 to 211. That means that Speaker Pelosi, who leads the Democrats, has a majority. She can't afford to lose a lot of her caucus, but she can pass bills on majority vote. And so the majority party has a lot of control in the House, and most of the bills that you see passed really reflect the priorities of that party. Now let's go over to the Senate, the other place where the action takes place. The Democratic majority there is the slimmest it could possibly be, 50-50, with Vice President Harris casting the tie vote. Most regular order bills in the Senate require 60 votes. That means 10 Republicans have to vote with the Democrats. That's a lot for Majority Leader Schumer to be concerned about, and he leads the Democrats in the Senate. There is a process called budget reconciliation. That is a big word. And what that means is that you can pass certain bills by a majority vote. However, it's a big however, they have to be primarily about federal expenditures or taxes. So the parliamentarian is the main player in that scene. She gets to say whether the bill meets the requirements of budget reconciliation. So certain bills can go through in that way, but most bills go through regular order, which requires 60 votes. Next. So where are we right now? What's taken place before the scene that we're in? 3 bills down, several to go. What has passed? The Coronavirus Aid, Relief, and Economic Security Act, otherwise known as the CARES Act, that's a lot easier to say, passed last spring. Consolidated Appropriations bills of 2021 and COVID relief passed in December. Those 2 bills passed through regular order. That is, they got 60 votes in the Senate. In March, we had the American Rescue Plan Act, and that bill passed through reconciliation. In the future, what is coming up? 2022 appropriations. Every year, the federal government has to fund itself. So we have annual appropriations. And then we have some of the president's priorities. We've seen the American Families Plan, the American Jobs Plan, lots of discussion about infrastructure that I'm sure you have heard. And then there'll be other bills that will get consideration in the coming weeks. What mental health and substance use dollars have already been passed? What money is already coming down to local communities? The Community Mental Health Block Grant, in December, half that money goes to states, half that money goes to CMHCs, community mental health centers. And March, $1.5 billion just passed. Last week, Secretary Becerra announced that that money is coming to local communities, has been released. Same with the Substance Abuse Prevention and Treatment Block Grant. Education dollars are coming to state and local education authorities. That money is general money, so it could be spent on mental health care. That is a permissible use, but it's not a required use. So advocacy will be needed to make sure that some of those dollars are used on mental health. Smaller grants, Project Aware, National Child Traumatic Stress Network, and others, all in those bills. And then you see some Medicaid options and additional federal matching assistance percentage for home and community-based services. What does that mean? Well, the FMAP, short form, is how much the federal government pays versus the state for a service under Medicaid. So under the law that was passed, that the federal government's going to pay more, about 10% more. So what does that mean? The state has more money to invest in new services or in enhancing the services that they have. Those services include mental health services. So we are going to need to be advocating to make sure some of that extra money is invested in mental health services. There are several Medicaid options that states can choose. One is mobile crisis teams can get an 85% match. That means the federal government will pay 85 cents on every dollar spent on mobile crisis services. Also, there is an option for postpartum individuals to cover them for up to 12 months. Another important option for mental health advocates because we want to see maternal mental health care improved. These are both equity issues between crisis services and maternal mental health, very important issues for advocates to be paying attention to. Next slide. This is a lot of information given to you very quickly. You will have these slides and they will have links to a question and answer document on relief funds that discusses strategies for finding out more about opportunities in your state. provides details and links to documents that you may want to review. And then also there's a link there to a guidance that the Center for Medicaid and Medicare Services has released that describes in great detail what the home and community-based services FMAP dollars can be used for. What kinds of things can advocates ask for? Next slide. So what's coming next? That's what has been passed. What do we have to look forward to? Well, one is the F2022 budget, right? Because we know every year the federal government has to be funded. The president has issued what we on the Hill call the skinny budget. And we call it the skinny budget because it's just the priorities. And then we get a much more complete budget from the president, and that is due to be released now on May 28th. So the end of the week, we should see that. But in the skinny budget, we already got a glimpse at some good things for mental health. $1.6 billion for the Community Mental Health Block Grant. That is more than double the previous year. And that means that some of these dollars that we've been able to secure in COVID relief will get expanded into year-by-year funds, which is a great thing if we get it passed. Now remember, this is just the president's budget. It doesn't mean it's passed until it gets through Congress. $10.7 billion for the treatment of opioid use disorder, and that's several billion over last year. $1 billion in brand new resources for school-based mental health professionals. That's very exciting to have more money for school psychologists, social workers, counselors. It's really a brand new budget item. Next slide. Behavioral health is getting a lot of attention on the Hill. So when we look at what is the landscape out there, we are seeing lots of conversations, lots of understanding that after COVID, you saw some data on that, mental health is a major issue for the country. And we're seeing new entities arise, like the new bipartisan Addiction and Mental Health Task Force in the House, and the Mental Health Caucus, which has for a long time been in the House. 11 mental health bills recently passed the House under an expedited process. Remember, I told you that the bills can get through with a majority vote. Now in that Senate, it's going to be more complicated, which is why we're going to need your voice to help us move those bills forward. But it is a very good sign to see those bills moving through the House. And we have had multiple committee hearings discussing all kinds of topics relevant to mental health, whether it be peer support services, crisis care, telehealth, COVID-19 and behavioral health. There's been a hearing practically every week where mental health has been front and center. But we need to keep that momentum going. Can't stop now. And that's where you come in. So next, my colleagues will be telling you about the different asks that we have in Act 1 of the play. And then you all need to get out there and make some calls in the areas that you care about. If we want this momentum to continue, we're going to have to make our voices heard. So that concludes my program notes, and on to Act 1.
Thank you so much, Mary. And yes, that was a lot of information. So let's break it down. What are we at MHA asking our affiliates and our friends to talk to their legislators about? Well, I'm about to tell you. So the first one is about funding. We heard Mary say that we have a skinny budget out. We're expecting the formal budget in 2 days, and we'll know more. But remember, budgets are only suggestions. So we want to say to our legislators, will you support $1.6 billion in funding for the Community Mental Health Services Block Grant? Will you support $10.7 billion for research, prevention, and treatment of opioid use disorder? And will you support $1 billion increase to mental health professionals in schools? Really important ask, big numbers with a B, billions. Next ask, please. Here's the second one. Will you ensure telemental health services, including audio only, many folks only have a phone, are covered by health plans at parity? That means covered equal to, even after the COVID emergency declaration expires. We've seen it work during COVID. We want you to support it after the declaration. Ask 3, please. Will you commit to supporting maternal mental health by voting in favor of the Black Maternal Health Momnibus Bill? Complications of pregnancy and postpartum period that affect mental health are the #1 complications of pregnancy. It's so important that we look at that, and we look at that for all moms. We want to see that Black Maternal Momnibus Act coming through, getting fully supported, because so many moms of color face outcomes that are disparate than to other moms. So very important. The Maternal Health Momnibus Act, the Black Maternal Health Momnibus Act. Ask 4, please. Will you support investments in local crisis centers, the kinds of things that we just heard Charis and Kelly talking about? And what goes along with that? Will you support the 988 Lifeline? And will you support new federal coordinating center? One more thing, when we talk about that Lifeline, there's important asks at the state level as well as of your federal representatives. And we want all these things to be in the next funding bill. Investments in local crisis, more money for the Lifeline, and a federal coordinating center in that federal bill. Ask 5, please. Will you support access to peer support services in Medicare by co-sponsoring the PEERS Act? Will you join Representative Chu and Representative Smith on their bipartisan effort to get peers in Medicare? A really important ask. And our 6th ask is, will you commit to reducing mental health disparities in children and youth by supporting equity, the Equity in Mental Health Act? Not just children and youth, but especially children and youth who are BIPOC children and youth and LGBTQ children and youth. And that's why we care so much about equity in the Mental Health Act. Karen's going to tell you how to take action. So now it's time. Karen, tell us how we can take action.
Hi, everyone. We are back, and we're so happy that you're still with us. We had several things that you guys can do to push forward our advocacy in this, final act of the play. So first things first, if you didn't receive our May is Mental Health Month Advocacy Mondays update, please join MHA's Advocacy Network. You can do so by visiting the Hill Day registration page or our advocacy webpage, kind of landing page, mha.org/advocacy. You'll get emails updating you of changes in Congress that we think are really important. We'll ask you to support and take action right away on an issue area. For instance, when our Peers in Medicare Act was first introduced last August, we were really excited by that and sent an email out to the Advocacy Network. Secondly, using our Advocacy Toolkit, the Before Stage 4 Toolkit, which you may have already downloaded, you can find your 2 U.S. senators for your state and your 1 representative for your congressional district, and then request a virtual meeting with them. Some members ask you to go through and fill out a web form on their website. Others will just receive email. You can just directly email their scheduler, and you can find that email address either on their website or by calling their district office or their Washington, D.C. legislative office. Those offices their staff are waiting to hear from constituents. They take time to go through and evaluate how many pros and cons came in, or support or against letters came in on an issue. So the meetings as well might take a little bit of follow-up. So I encourage you, if you don't hear back after your first meeting request, just follow up and ask again. You can leave a message and send emails with your story. We create form letters in our through our action alerts that you can use. However, personalizing those messages and adding a couple sentences about truly why mental health is personal for you, why peer support worked for you, or how you see it improving the community makes the most difference. MHA can provide the data and the statistics and kind of the high arching overview. However, when you put in your personal story, that really brings it home for your members. And then we talked about action alerts and personalization with the storytelling. Finally, social media, as we saw with the last administration, has become a huge part of the kind of political process and raising your voice. So we encourage you to share MHA's graphics, MHA's language with your legislators, or creating your own and tagging them directly. Members of Congress have a constituent badge, which is discussed in more detail in our advocacy toolkit. That constituent badge in Facebook allows them to know you are a constituent, so they will directly go back and forth with you and communicate and take note of your concerns. In Twitter, members like to have attention, so if you highlight what you're thankful for and then go into what else you think they can be doing, I think that's a really good way to get their attention, and their communications directors definitely flag those for you or for them. We're using MHA Hill Day 2021 as our hashtag. If you would take action today, before end of day, 6 o'clock today, Twitter picks up all the hashtags that are being used often and puts them in a trend, and then we can track how many tweets are out there on these issues. And with Facebook, we also have the ability to track hashtags more recently as well. So on those two modes of social media and even on Instagram, we encourage you to post as often as you can. If you're unable to take action today, or you can only take one action today, we encourage you to go back later in the week, tomorrow and Wednesday, and also take action. The more you take, the more powerful our voices are. And really, members of Congress get the message from 1 or 2 constituents, but when there's 5 or 10 or even a group of 100 people saying the same thing, that really brings everything home. So I encourage you to think about your storytelling in 2 or 3 sentences, maybe. Figure out what you want to say about how you've been impacted by a person or your own lived experience. And then share that with your member in your tweet, your post, your email, and your phone call. You can even practice your story aloud a few times in the mirror, because that helps you really bring the message home and be confident. And just like you practice a 30-second elevator pitch, you can do that with your own story and tell it wherever you go. If you run into the member, if you even run into not your member of Congress, but a local county commissioner or otherwise, these people all need to hear from us about the importance of mental health funding, priorities, and policy changes. And ensure that your story ends with an S. And though you can choose one of the 6 acts that Debbie went over just now, and we're focusing on those for the rest of May, and we'll be working on them for the rest of the year. You can also come up with some other asks that might be more targeted to your local area. So if you know of a particular program that worked for you, you can just ask that that particular program at the local level continues to receive funding. We encourage you to do all of these things. And at this time, I would love to introduce our closing charge so that you know all of the things we discussed today in the last 55 minutes. Thank you for staying with us. We have 6 priority asks on funding, telehealth, perinatal mental health, including mother and child and family, crisis services, peer support, and equity. And then we have the actions you can take. You can tweet, post, meet virtually, make a call, and leave a voice message if they don't answer, send an email, and also invite a friend to join you. We really appreciate you joining us today. And I'm really excited now to turn it over to Casey Badmington from Senator Cortez Masto's office. Senator Catherine Cortez Masto is MHA's lead bill sponsor for the Peers in Medicare Act. And Casey has a wealth of experience working both across the aisle and within the Democratic caucus to try to build support for peer support issues. Though she has not yet reintroduced the peer support bill in the 117th current Congress that we're in, we're really excited that we have such a strong leader and in her boss to reintroduce this bill. And we can hear now from Casey.
Thank you for that, Karen. I appreciate it. Glad to speak with folks and really appreciate the work that everyone's doing to raise the profile of mental health issues on the Hill. It's something that members of Congress are hearing about a lot from constituents, really no matter what the constituents are calling in about. We had a meeting with the Cattlemen's Association the other day, and they talked a lot about the impact of COVID-19 on the mental health of their members. So you're not alone in terms of the sort of constituents who are raising this among offices. Offices are, they're really excited to hear about things that they can do to help. And so they really welcome these very concrete asks that can help make a difference for folks working in this space. I'm really glad that that folks are being encouraged to share their stories. I've always found, both as a staffer and I will say too, that members themselves are really moved by stories. They tend to repeat them among their colleagues. They will sometimes repeat them in hearings or public settings if they get permission to do so. And those anecdotes, I think, can really move the ball forward. We've seen that, in previous instances. Talk about things like ACA repeal, I think, is a really good example of something that that was moved or not moved by sort of the sheer power of stories. I think too, it's also important to talk about, especially if you have the opportunity to talk with a staffer or a member who represents you, to talk about the impact that is specific to you locally. Senator Cortez Masto obviously represents Nevada, so hearing about things in Las Vegas or Reno or in Nevada's rurals are really, really helpful to her to have a concept of what's going on in state and how she can be most helpful in addressing those issues. As Karen said, we are excited to be moving forward on the Peers bill. I think we're very close on a Republican, and so hopefully we'll be able to get that reintroduced soon. And then there are a couple of other pieces of legislation in the crisis space and in the Peers space that we are hopeful to be moving. The Senate Finance Committee, on which the senator sits, and the Senate as a whole are prioritizing mental health and mental health legislation, mental health funding. So these will be friendly conversations, I think. There's I think a broader understanding of the needs in this space than there has been in a really long time. So thanks so much for your work to advocate for these issues.
Thank you so much, Casey. If anyone has questions, we have just like a minute or two, and we're happy to follow up with you guys offline as well. Please put your questions in the chat. Remember to download MHA's Advocacy Toolkit with all of the asks as well as talking points. We have our social media graphics that you can download and use from the Hill Day website. And we're just so excited to be closing out this year's Hill Day kickoff. Thank you again, Casey. And again, questions might come in. So we'll be here for another
We've
minute.
got a couple, Karen. I'll be happy to start with one about what's the timeline for our asks. Well, as Casey said, legislators and their staffs love to hear from you. It's never too early. It might be too late. So we're saying certainly before the end of the year. Budgeting, as soon as the budget comes out, do it. Do it often. As we say in Philadelphia, early and often. We want to make the ask, and it's okay to ask them more than once. And it's okay to share your stories and to share your stories with both senators and your representative, and to encourage your friends, your colleagues, people you're working with, share their stories as well. So the timeline is now. It's never too early, as soon as this webinar is over, and to ask more than once in different ways. So you can ask, as Karen said, through social. We had a question come in earlier about what MHA is doing with veterans and peer support. MHA National is involved in a number of projects where we're looking at how the VA is working with veterans and suicide, and peers play an important part of that. Our affiliates all across the country, a number of them do have programs where they do special outreach to veterans, and they of course use peer support, and veterans have been very active in the peer support realm. And I'm afraid we're out of time, but we're so glad that you could join us today. Even though our Hill Day was virtual, we're glad you were here. The information's available. You have the links, and don't forget to download our Advocacy Toolkit where they're all spelled out, and please take action. We look forward to seeing you again soon. Thank you so much.